Hello, everybody. I'm Phil Jennings, the Chief Executive at the Innovation Agency. It's a real pleasure for me to be speaking to you today at this giant event in Alderhay. If you'll bear with me for one moment, I'm just going to begin sharing my screen as I have some slides today. Okay, so here I am. You may be forgiven for thinking I'm a reporter by this slide, but actually I'm not. I'm a GP by background, but as I said, I'm now the Chief Officer here at the Innovation Agency. We're one of the 15 AHSNs across the country. Here I am promoting a number of the medtech products we've been supporting in the last year. Got the heart flow CT coronary angiogram at the top of the slide there. And then in the lower right-hand corner, the Securacath device for maintaining the position of PICC lines. And that's just two of the many products that we've been supporting through this year, but a little bit more about that later. So today, what I thought I'd do is start by taking some stock of where we are as a health system. I think with a focus on inequalities to healthcare, which have been brought into such sharp focus during the pandemic. And then I'd like to talk about innovation. So what is it? Why do we need it? And then maybe take a look at some of our current programs. And throughout the presentation, want to bear in mind the kind of four main areas in which we work to support innovation. So that's new medicines, new medtech, pathway redesign, and then real world evaluation. So to begin with, I thought we'd just spend some time looking at the UK as a nation in terms of our health outcomes. I've taken the data for these next few slides from the Institute for the Study of Civil Society that have recently published their International Healthcare Outcomes Index, which is quite a detailed report that you can download yourselves following that link in the slide. We're going to look at a series of graphs which will show the UK against a number of similar European and world economies. So to start with here, we're looking at healthcare expenditure as a percentage of gross domestic product. The UK is denoted as GBR on the graph, which is the thick red line. And we're comparing two time points here, 2011 and 2019. So in both cases, you'll see the UK is kind of in the middle of the pack there with 9.8% of GDP devoted to healthcare in 2011, increasing up to 10.2% in 2011. It's also important to note that all of the data here is pre-pandemic. You'll see that the USA consistently has devoted the highest proportion of its GDP to health, spending 6.8%, with France and Germany swapping places at 2 and 3 over the two periods that we're looking at here, 12 and 11% respectively. Now, when we compare that, this next slide is looking at the ranking of life expectancy. So it's the same 19 countries, but a few points to note. So I think first of all, most strikingly, there's not a direct correlation between what's spent on health and the outcomes. And in fact, it's completely the opposite with the United States example here at the foot of the table in 2019. And this is, in the States at least, thought to be due to a number of factors: the lack of universal health coverage, a high rate of neonatal deaths, poor diet, and the opioid crisis. But then here in the UK, you can see also some fairly worrying results. So a fall in life expectancy, which has been quite marked over the two periods that we're observing here. And the reasons we can look at largely being down to the socio-economic impacts of austerity on the wider determinants of health. So by this, I mean things like employment, education, crime, housing, and the fact that particularly the cuts to local authority budgets over this time period have had quite a pronounced impact on those wider determinants. And again, those impacts have been felt most acutely in areas of high deprivation. And this is opposed to another health reason. So again, before the pandemic, we haven't had a particularly adverse weather challenge or other medical reason why we should see such a dramatic fall in our outcomes in the UK. Now, looking at the reasons that underline that from a clinical pattern, first here we're looking at some cancer data, and again it's fairly depressing to see the UK survival rates from these common cancers, breast, colon and lung, again right down there at the bottom of the pack with only modest improvement, if at all. And then similarly, if we look at examples of chronic disease, and I've chosen cardiovascular disease here, there's a similarly gloomy picture. So we can see here the survival rates after stroke on the left, after heart attack on the left and stroke on the right. Again, the UK right at the bottom of the pack. And if you think what's happened during COVID, unfortunately, this situation has only got worse. So in fact, we're facing a tsunami of late cancer diagnoses at the moment. And we know from audit data that important risk factor controls such as blood pressure monitoring or medicines optimization for lipids has all deteriorated during COVID. And it gives us really an unprecedented challenge now as a health system, even to just get back to where we were before, let alone to try to improve the UK's position when compared to some of our international comparators. Now, looking within the UK, this performance hides a significant amount of variation within our own country. So here in Liverpool, for example, our local outcomes are in fact much worse than in other places in England. And I think it's worth, again, spending a little bit of time looking at this and seeing some of the challenges we have on a regional basis as a nation. And for this illustration, I'm using the NHSA COVID-19 report as a data source, again, which you can download by following the link. So this illustration comes straight from the report, and here we're looking at a representation of life expectancy illustrated through the east and west coast main lines. So stations that are in green are 10% better than the average life expectancy. Stations in yellow are about the average, and stations in red are 10% or more below the England average. And we see males on the left and females on the right. So straight away you can see that life expectancy drops off as you travel north from London and is at its poorest in the northeast and the northwest of the country. And you'll also see that this profile is more pronounced in women versus men, who appear to be particularly affected with some of these recent trends of falling life expectancy. And as I mentioned earlier, whilst differences between the north and south have been known about for quite some time, COVID has brought these into really quite sharp focus. So we saw worse performance from direct COVID illness. So that's this first figure, an additional 12.4 per 100,000 deaths attributable to COVID alone in the north of England. But importantly, a more pronounced excess mortality from all causes, which was nearly an additional 60 deaths per 100,000. And again, this illustrates that although we may be moving into a phase where we're living with COVID, the impact of COVID is still with us, particularly in the effect that it's produced with chronic disease management and cancer diagnosis. And importantly, that this effect will be most notice in those areas of high deprivation. So partly as a response to this, NHS England has recently launched its Core 20 plus 5 framework. And this is the lens through which we'll be looking to start our response to tackling these inequalities. Strategically, it's a hugely important driver, and it will certainly signal the agenda in research and innovation in the near future and medium term, and also form an important part of ICS strategies. So the core element in the framework focuses on the 20% of the population with the highest levels of deprivation, which is defined through the indices of multiple deprivation, which you'll remember have 7 different factors that are looked at. The plus element is bespoke to an individual ICS area, and this describes additional communities with poor access to healthcare. So it could be, for example, a specific ethnic group, or perhaps a coastal community in some areas. But essentially, this is for the ICS to define. And then finally, there are 5 clinical priority areas. And at the policy launch, these are maternity, severe mental illness, respiratory disease, early cancer, and hypertension. Now, these clinical areas are likely to change over time, but at present they've been chosen because it's believed these represent the areas of greatest need, and we're being asked to immediately align our plans. So clearly we're facing major challenges coming out of the pandemic. And this is set against what we already recognised as problems of an ageing population and the demands on both the supply and the resilience of our workforce. So more than ever, we do need to innovate our way out of trouble. And really, that's what I'd like to talk about now. So many of you will know that Einstein's commonly misquoted as saying that the definition of insanity is repeating the same actions and expecting different results. So I think the point here is that unless we make changes to both the treatments we provide and indeed the manner in which we provide those treatments, then it's very unlikely that anything will significantly change. And this, of course, means shifting the focus of care from treatment to prevention, but equally shifting the point of care from a hospital setting through community settings and on into self-care. And this is where innovation comes in. And innovation is the idea of using a new product, or maybe a product that's not new in itself, but new to health, but produces a step change in the way that we deliver care. And I use the definition to cover all the aspects of the work that we're involved with. So, as I mentioned before, medicines, medtech, pathway change, and evaluation. And when it comes to evaluation, this is particularly important, where evaluation or evidence is a barrier to innovation. And the further idea here is that there are multiple stages to innovation, and all of these need to be completed to have a successful innovation. So to begin with, you start off with an invention, so something that's new or a discovery, and then that needs to be tested in a service setting to show that it can add value. This is particularly important in the NHS. And then thirdly, that needs to be spread, so it becomes part of normal culture and practice. And it's only when all of these components have been satisfied that we can truly say that we've got an innovation. Now, I think we all have a kind of romantic idea of what innovation might be. The fact that we might be in the bath one day, or maybe walking the dog and just happen to stumble across the cure for cancer or something else. But unfortunately, that's almost never true. And in fact, innovation is a risky business, and almost always starts with risk. And that might be a personal risk. So stepping out of a clinical area in which you're familiar to do something different, or sometimes a financial risk. So there's many stories of innovators who've had to remortgage their house or take personal risks to further their ideas. And the other thing that's common throughout innovation is failure. And failure is something that we have to embrace if innovation is to succeed. Almost all of the great innovations through history are marked by a series of trial and error, but not giving up and recognizing that every time we fail, we're one step closer to the truth, to something that works. And we need incredible perseverance as individuals and as systems to be able to follow an innovation through this journey. So it's difficult. Innovation is a difficult thing to be able to create in any environment. And it's particularly difficult in business where we're under stress. And clearly, we're very much under stress at the moment in the NHS. So it's incumbent on us as NHS leaders to create the environments for innovations and indeed innovators to thrive. So we need to give permission and room for our staff to be able to work differently without fear and be allowed to experiment with new ideas. Now, yes, we always have to keep patients safe first and foremost, but that doesn't mean every change requires a randomly controlled trial. And we do need to get much better at using alternative forms of evidence and rapid evaluation cycles so that we can really give our patients the reassurance that the changes we're proposing are safe and effective. And that's really where we come in. So we're one of 15 academic health science networks throughout the country. We will be 10 years old next year. So we came around about the time of the Lansley reforms and are still going, even though the CCGs are off. So we're currently operating under a license until March of next year in a relicensing period as we speak. So the Innovation Agency, which I lead, is on a northwest coast footprint. So that's Cheshire, Merseyside, Lancs and South Cumbria, home to about 4.2 million people. And we're co-terminus with our strategic clinical network and our clinical research network, but with 2 ICS regions that are emerging. Actually, that gives us a fairly simple footprint compared to a number of colleagues who may have 3 or 4 ICSs on their patch. And we changed our name shortly after being formed to the Innovation Agency. We spent a long time trying to struggle to describe what it was that academic health science networks really did, and really to kind of bring home the fact that we're very much focused on promoting innovation. So our job has this kind of triple aim. So we're there to improve health, which I suppose is a fairly universal claim for any NHS organisation. But for us, we're trying to improve health linked to innovation, and particularly now where this involves innovations in population health and prevention and aligning to things like the core 20+5, as I've described. Those improvements are also designed to drive down the cost of care, and indeed, great care and financial benefits often go hand in hand, but it does mean that we need more than just a rudimentary understanding of financial flows within the system. So the relationships between, say, primary, secondary and tertiary care, the impact on block contracts, understanding capital needs, training and implementation, and also a commercial understanding that we can work with industry partners, both big and small. And then importantly for us, we have a direct remit to stimulate economic growth in our region. And this is particularly important for us here in the Northwest, where there are high levels of deprivation and health inequality. So much of our challenges are rooted in these wider determinants that I've spoken about. And we work very closely with our LEPs and other bodies that look to promote the economic growth and buoyancy of our region. And indeed, we have a a whole commercial team at the Innovation Agency. And I think one of the things that we're most proud of are the number of new jobs that we've created, or the investment that we attracted to our region. I usually get asked, where does the money come from? And so you can think of us as a organisation with both a national and regional focus, which is about a 50-for-50 split. So NHS England and Improvement and the Office for Life Sciences commission us to undertake a number of national programmes, and these are duplicated across the entire AHSN network. So together we do act as that vehicle for rapid spread and adoption nationally. And that's the push into the system for new innovation. But equally, the other half of our work is there with our systems, and this is now really ICS based as the kind of new currency of the NHS. And so we work with our ICSs to articulate that system need, what's needed here for us in the Northwest. And that's the pull part of what we do. And then we look to use that knowledge to shape new programs and products in the future. So currently these are our national programs. I'm not planning to go through this slide, but really it's just to give you an idea of the kind of national work that all the AHSNs are involved with across the country. So that you can see there in that first box on the left hand side, these are the national products and programs that are commissioned through the Innovation Research and Life Sciences team in NHS England. And it's a series of national programs with quite a big focus on cardiovascular disease, lipids and blood pressure, together with a number of specific product sponsorship, either through the MedTech funding mandate, the Rapid Uptake programme, or some other bespoke products that we support. And then in the middle box there, you can see there's a series of patient safety initiatives which we're commissioned to deliver in specific care settings. And the examples there are nursing homes, maternal and neonatal system safety and mental health. And then finally, from the perspective of the Office of Life Sciences, it's our role, as I mentioned, to boost economic growth in our particular region through a combination of needs articulation, through signposting to innovators, through spread and adoption of products, and then finally by supporting real-world evaluation. And then in contrast to that, there's a number of other work streams that we do at a local level in combination with our ICS teams. And again, I'm showing you this really just to give you a flavour of some of the work that we've been undertaking over the last 12 months. At the top there, the pulse oximetry and virtual wards programs led by the AHSNs were our major contribution to the COVID effort. But again, you'll see now we're involved in a number of other local initiatives around early cancer diagnosis, some respiratory work around pulmonary rehab. And then at the end there, again, some work looking at how it is that we can work differently, new ways of practicing medicine, new ways of engaging with our patients and communities, all of which hopefully puts us in a good and better position for moving forward. So I'm going to bring things to a close there. I suppose just finally, just to share with you this final slide of our team. So you'll see there's a fair few of us here, and we have quite a diverse range of skills and experiences, and that covers the health experience that you might expect with, medics, physios, dietitians, and others in the team, but also a much broader range of backgrounds, including commercial experience, our coaching academy, digital experience, and comms. So really, whether you're a healthcare professional listening to me with a great idea and wondering where to go next, or perhaps you're a new startup with a great product, but you're just finding it difficult to tap into the NHS, the message that I'd leave you with is that we're here to help. And it's our job to help you succeed, so that by utilising innovation, we can really help to meet the challenges of the future. So thanks for listening. And once again, thank you for inviting me here to Alder Hey and to be part of this great giant event once more. And please do get in touch either via our website or through the details that you can see there.